Good morning, everyone, and I would like to thank you for the opportunity to speaking at your conference today. I would very much have liked to have been there in person, but given the situation, I guess we're doing everything by video today. So on the theme of new therapies, I've been asked today to address the issue of the new long-acting therapies, which patients will benefit most. And these are my disclosures. So really, my talk today is really going to focus on the only long-acting therapy that is currently approved. That is a drug called Cabenuva, which is an injectable antiretroviral agent that contains two compounds. One is long-acting rilpivirine, which is a member of the non-nucleosides, together with long-acting dolutegravir, which is a member of the integrase inhibitor class of drugs. And so there have been a number of clinical trials which have led to the licensure of this agent. The first was the LATTE study, which is a dose-finding study which compared oral cabotegravir to abacavir and 3-TC. The FLAIR study that looked at treatment-naive patients and compared this new compound to Triumec. There was then the ATLAS study, which was a switch study in patients with an undetectable viral load compared to staying on their standardized therapy. And then lastly of all, the ATLAS 2 study, which was a comparison of the injections every 4 weeks to every 8 weeks. And overall, what did these studies tell us? So first of all, they told us that the injectable agents worked as well as the oral agents. And again, these trials were designed as non-inferiority trials. There were a few patients who developed virologic failure, and some of these patients did develop resistance to one or both drugs in the combination. In general, these were related to cases where there were issues of adherence. Luckily, there were no major adverse reactions. And the optimal timing for these drugs appears to be an injection every 30 days, but the 60-day schedule did work for most patients. And the failures in ATLAS 2 tended to have multiple risk factors, including obesity, clade A virus, and underlying baseline mutations to agents in the combination. So if you're in your practice, which patient would you think about for one of these long-acting injectable therapies? Well, first of all, obviously those patients who don't like to take pills or have difficulty in taking pills, or those individuals who have trouble remembering to take pills, even though you use all the adherence tools that are available for us today. But I think most patients who really want to go on to injectable therapy tell us that story that when they take a pill every day, that reminds them of their HIV. And therefore, in order to go to an injectable agent that would be every 60 days or every 30 days, they're able to kind of forget about their HIV and live a more normal life. And the other major group, or was a major group, is those who might have a lot of travel and therefore may have difficulty in taking pills with them when they're crossing borders and going different places. And then again, those who have difficulty in maintaining regular appointments if they could extend their treatment. But what could be a problem with an injectable drug? Well, obviously the one that everyone's concerned about is the pain of the injection. Secondly of all is that this current cabenuva has to be administered by someone. And so that's a bit of an inconvenience that our patients are needing to come to some place where it's injected, and they need somebody who's qualified to do it. Obviously, a concern is if you have an adverse reaction and the agent has been injected, how long might that adverse reaction last? Of course, women are certainly concerned that should they become pregnant on an injectable drug and that drug is in their system, whether or not that drug may cause some harm to their baby. Clearly, these drugs can last for a long time. So if you develop an intercurrent illness that requires some sort of treatment that may have a drug-drug interaction with the agents in the injectable compound, that could be a problem. And then as we move forward, if we end up with different drugs that are all injected, but they have different schedules, that could serve to be a problem practically. So what about this whole concern about the pain or the injection site reaction. And many of us who've been in the field for a long time remember the T20 days when patients developed very painful nodules that really was dose limiting for that drug. Well, this here is data from the FLAIR study showing that, yes, with the first injection, a lot of patients did complain of an injection site reaction, but this declined over time. And whether or not this became the patient kind of getting used to the discomfort associated with the injection, or whether the nurse got better at giving it, is not clear at the time. But the issue is people did not get these painful nodules like they did with T20. It was just really some pain at the injection site. And the most important thing is it didn't last for very long, and very few people had to discontinue the drug because of the injection site reaction. But people like this, and this was data from Atlas 2, and I think many of us, when we thought about the injectable trials, we thought patients are not going to want to come in and get a needle every month. But as you can see from the Atlas trial, the vast majority of people preferred to have the injectable drug as opposed to the oral therapy, and clearly a slight increase in those would prefer every 8 weeks as opposed to every 4 weeks. Now, of course, we all have to take this with a grain of salt, because obviously patients who are going to enroll in a trial of an injectable drug are going to be those that are going to want it or going to accept it, and therefore these results may not be applicable to everyone in your population. But clearly those patients who did get in these protocols and got to experience this did find this an appropriate way to be treated. But the big concern for clinicians is, what about this long PK trail? And so this is data, again, from the Latte study, looking at cabotegravir here and rilpivirine here. This is the amount of drug that's necessary to kill off the virus. And you can see that following an injection, these medications can remain in a patient's system for a very long period of time. And as you can see, out to 12 months in many circumstances. A similar thing has been found in women who have gotten pregnant. And so this was data from women who were enrolled in the injectable trials who ended up pregnant during the trial. Obviously, pregnancy was a reason to withdraw from the study, but they continued again to watch drug levels in these women throughout the course of their pregnancy, and they did persist. So this is really a concern to people, one, for pregnancy, as to whether or not these agents might impact the developing fetus. And of course, we have very little data now to know that. The second concern is that if these drugs continue to be in the system for a long period of time and drop in terms of their drug levels, will that eventually lead to resistance to the compounds? Obviously, that should not be a concern if you switch them to another antiretroviral drug and maintain virologic suppression, but it could be a problem in a patient who has poor adherence, who stops taking their medication and then has this long pharmacokinetic tail. So what about for you? What are the challenges of you implementing these injectables into your clinical practice? Well, one is they need to be scheduled because these drugs have to be ready when the patients come in, because they're not going to want to sit in your clinic for the time that it's going to take for the pharmacy to get it ready. The current schedules do recommend that you have an oral lead-in to ensure that the patient is going to be able to tolerate the components of the medication. And then that becomes confusing when you start with something oral and then go to something injectable. You're going to need to have supply in your office. You're going to need a way in which you can get it reordered on time, that you can get it stored and you can prepare it. Who's going to give this? And if you're a small clinic, you need somebody who's prepared to do it. And what if you have one nurse and she gets sick? Who's going to be your backup person? We always need bridging. There may be circumstances whereby somebody's going to miss an injection, be out of town, have some other issue. And so you do need to have that oral option for the bridging period. What do you do if somebody doesn't show? And in particular, we're worried about that long pharmacokinetic trail. How do you contact them? What if they're homeless? What if they live on the street? How do you find them? Obviously, injectable drugs are going to cost more than oral pills. And I think we're just at the very early stages of the regulatory process of this compound, and we really don't know who's going to pick up the cost. And then, of course, there's always the unforeseen problems. And clearly the COVID epidemic has demonstrated to us that things that run smoothly all of a sudden can go out of whack. And what do you do if you're in a hospital and you cannot bring the patients into hospital in order to get their injection? So this is data that was presented from the Atlas 2 trial, and this was data from the providers. What were the good things and the bad things about the injectables? And so as you can see, and these are data from across the world, the main advantages for patients was their lifestyle, their privacy, their convenience. They all thought that these were good things. What were the concerns of the providers? Well, many of the things that I've just mentioned. What happens if the patient doesn't get there for their injection appointment? What about if they miss and they have this long PK trail and get drug resistance? What if they move out of the area? Are they going to go to a clinic where they're going to be able to continue to give this medication, or a switching provider who may not know very much about it? Drug interactions. So if somebody develops hepatitis C or some other tuberculosis during the course of their therapy, how do you deal with the drug interaction? So those were the major things. The oral lead-in, less concern, but still of concern to some people. This will not be the end, and I think that this cabenuvadir is just setting the stage for more long-acting drugs. As many of you know, there is a drug called islatravir, which is a member of the NNRTI family, which is currently oral, but may be available as a subcutaneous injection that may last for several months. Gilead is also developing a capsid inhibitor, which may be subcutaneous. And so these different formulations may take away some of those barriers of the current long-acting compounds that we currently have available to us. So in conclusion, long-acting therapy, cabenuvadir, which we currently have, who might benefit most? So I think the main categories are those who do not wish to take oral daily medications, those who are reliable enough to ensure that the injections can be administered to them on schedule, those who don't take any medications that may result in drug interactions, and those who do not have any underlying resistant mutations to any component of the combination that might further compromise their therapy. I thank you all for your attention.